cigarette smoking is called chronic bronchitis. And as a result, when someone has emphysema, usually they have some component of chronic bronchitis because both of those diseases have the same etiology. Now, when someone does present with emphysema, there really is a whole spectrum of combinations, emphysema and chronic bronchitis. Sometimes a person has emphysema and they have a small component of chronic bronchitis. Sometimes they have emphysema and a major component of chronic bronchitis. There's a whole spectrum of patients. At the ends of this spectrum, we have someone who has pure emphysema, no chronic bronchitis, and we have someone at the other end that has emphysema and very severe form of chronic bronchitis. We have names for these extreme forms of patients. We call them pink puffers and blue bloaters. The pink puffer, illustrated here, is generally someone who just has emphysema. It has very little of any component of chronic bronchitis. Now again, the individual is going to have trouble breathing. The airways are collapsing as he exhales. And so typically you'll see this person kind of leaning forward. Usually if the belt is loosened, it just makes it seem like it's easier for him to breathe. Very often they're very thin. And that's because usually they're mouth breathers. And if they're eating something, then they can't breathe, and so they tend to eat less. They're also expending a lot of energy just trying to move air in and out of their lungs. Okay? They are well oxygenated though, and so they're pink. They're not cyanotic. These are called pink puffers. Okay? Now we've got the blue bloater. This is the other end of the spectrum. This is a person with emphysema that has significant chronic bronchitis. Now we'll talk about chronic bronchitis next, but it's a disease in which the airways are chronically inflamed, and as a result, they're producing a lot of secretions. And these secretions occlude the airways. And so not only do you have emphysemic trouble exhaling air and moving air, but on top of that, you have a lot of obstruction in the airways. These people are not breathing very well at all. They're not well oxygenated. They tend to be cyanotic, hence the blue. Also, they tend to be very lethargic because they're retaining a lot of carbon dioxide. That makes them acidic, that makes them lethargic. And so they tend to kind of be very inactive. They put on a lot of weight. They're cyanotic, their nails are blue, their lips are blue. They're kind of overweight, and so we call these people blue bloaters. Most important thing for you to remember, pink puffers, emphysema, blue bloaters, emphysema plus chronic bronchitis. That's really the only thing I think you have to know about pink puffers and blue bloaters. Okay. Any questions on that?
Is the chronic bronchitis caused by the emphysema or vice versa, or they just appear together?
They have the same etiology. They're actually caused by, one doesn't necessarily cause the other, but they have the same etiology. So cigarette smoking will cause chronic bronchitis as well as emphysema. Yeah. And these diseases could lead to other changes in the lung. We'll talk about something called bronchiectasis might be a consequence, but emphysema doesn't cause chronic bronchitis. Chronic bronchitis doesn't cause emphysema. Emphysema, its pure form, is not an inflammatory disease. Chronic bronchitis, of course, is an inflammatory disease. Okay. Anything on this? All right, so I'll understand the mechanics of emphysema. Now let's take a look at chronic bronchitis. Here's another disease caused by cigarette smoking. There are other causes, but again, cigarette smoking is the most prominent cause. Cigarette smoke, very irritating. If it's inhaled, it's going to irritate the airways. The airways are going to become inflamed, and they become chronically inflamed. They become inflamed, characterized by an infiltrate of all types of inflammatory cells. But if you examine the inflammatory cell infiltrate, you'll notice there's all kinds of different white blood cells present, but there's one cell that's conspicuously absent in chronic bronchitis. And which one is that? The eosinophil. Yeah, the eosinophil is not present. The eosinophil does not characterize chronic inflammatory infiltrative chronic bronchitis. That's something you see generally with asthma. And so, in fact, that's one of the major differences between asthma and chronic bronchitis. Both are diseases where the airways are chronically inflamed. With asthma, you have this eosinophilic infiltrate. Chronic bronchitis, you don't. Now, lots of things irritate the airway in chronic bronchitis. Again, cigarette smoke being one of the most common ones. There are some pollutants that can actually cause chronic bronchitis. There is sulfur dioxide that, when inhaled, turns into sulfuric acid, and that, of course, irritates the airways. All other kinds of industrial pollutants. There tends to be a much higher incidence of chronic bronchitis in industrialized areas, highly populated areas where you have manufacturing giving off a lot of toxic gases as a result. Okay, let's talk a little bit about the definition of chronic bronchitis. So chronic bronchitis being an inflammation of the airways going to cause the person to cough. Airways are inflamed, people cough. The technical definition of chronic bronchitis is persistent coughing for 3 months in 2 consecutive years. So basically, if you're going to follow this denotation, you can't make the diagnosis of chronic bronchitis essentially for 2 years. Well, that's the strictest denotation of the word for chronic bronchitis. Generally, we can make a tentative diagnosis of chronic bronchitis earlier than that. In some cases, chronic bronchitis is constant. People are constantly coughing because of the irritation. In other cases, people have a seasonal form of chronic bronchitis. Maybe they're sensitive to something in the air that appears seasonally. And whatever the case, the airways are chronically inflamed. Now, we mentioned before that when the airways are chronically inflamed, they produce a lot of secretions. Chronic bronchitis is a disease in which a person produces lots of secretions in the airway due to this chronic inflammation. And one of the characteristic features of chronic bronchitis is not only is the person coughing, that cough is always productive. If they don't have a productive cough, that's not chronic bronchitis. Chronic bronchitis is characterized by a production of a lot of secretions that are coughed out. Okay, let's take a look at this. Take a look at airways that are chronically inflamed. Again, we have a normal airway, nice patent lumen, good sturdy airway wall. Not too thick, not too thin. Over here, we have an example of an airway that's chronically inflamed. Again, the lumen, the airway. Notice the airway wall is thickened. That's, of course, chronic inflammation. That's edema, structural changes. The airway wall is naturally going to thicken. Look in the lumen, a lot of secretions. And nothing here that's not expected. Okay? That's chronic bronchitis. Okay, let's have a look at the chronic inflammation of chronic bronchitis. Here's a section through an airway that is being damaged by a lot of chronic inflammation. Okay, we have the lumen here. Okay, we have the airway wall here. You notice the airway wall is lined by the pseudostratified ciliate epithelium. Okay? Within the lumen of the airway, you see a lot of inflammation. Okay? A lot of inflammatory cells here. That's going to be very damaging to the airway wall. Whatever's causing that inflammation is going to be very damaging to the airway wall. The inflammation will cause the epithelium to ulcerate. And ulcerate and erode. You can see the epithelium here is kind of peeling off the wall of the airway. Okay? That's because that pseudostratified ciliate epithelium is pretty delicate. It's not going to be able to tolerate this kind of inflammation for very long. And so the epithelium just kind of sloughs off. Now, that epithelium will regenerate, but depending upon the extent of the inflammation, instead of regenerating a pseudostratified ciliate epithelium, it might be replaced with a squamous epithelium. So one of the common features of the airways of people with chronic bronchitis is a squamous methylation. take a look at that. Right, let's compare the airway architecture of a normal airway to that of someone with chronic bronchitis. Here's again a section through normal airway. Now you can see the mucosa here, the submucosa, and there's the support cartilage. And there's the lumen up here. First layer of the mucosa is going to be this epithelium, pseudostratified ciliated. You can see the lamina propria. Within the lamina propria, you see some inflammatory cells. Again, that's normal. Your airways, just like your GI tract to some degrees, normally inflamed. It's called physiologic inflammation. Most of that inflammation just consists of sentinel cells. They're just kind of patrolling the area, making sure no bacteria invade. You got a very thin muscular mucosa. In fact, it's so thin you can't really see it in this section. Below that, you've got these submucosal glands. These are mucoserous glands. You can see the typical thickness of that of those glands. And then we have the cartilage down here. Everything looking good. Okay, over here, we have, by comparison, again, the architecture of an airway, someone with chronic bronchitis. There's the lumen. This is the mucosa here. That's the epithelium. The epithelium is not normal there. And if you zoom in on the epithelium, you'll notice it's a stratified squamous epithelium instead of a pseudostratified ciliated epithelium. Something we expected. The inflammation does damage the epithelium. That epithelium is pretty delicate. It probably will regenerate as a metaplastic epithelium, namely a stratified squamous epithelium. So the first problem we see is squamous metaplasia here. There's the lamina propria. Look at that lamina propria. Look at the clear spaces. What are those clear spaces? Fluid. Yes, that's edema. It's all edema. Edema is caused by the inflammation. You can see there's extensive amounts of edema here. That thickens the lamina propria. Look at the muscularis mucosa, how thick it is. You can't even really see it here. Over here, it's so thick. It's just chronicity of the disease. Below that, you can see the submucosa. It is filled with glands. The glands have become hyperplastic. They're taking up a lot of the room in the submucosa. In fact, that increase in submucosal gland thickness is one of the characteristic features of chronic bronchitis. If a pathologist is going to diagnose this condition, one of the diagnostic criteria includes a measurement of the thickness of the submucosal glands. The submucosal gland thickness would have increased. That's one of the defining histologic features of chronic bronchitis, is its increase in thickness. And then, of course, you can see the cartilage. Now, to assess the thickness of the submucosal glands, generally what we do is we measure the thickness of the submucosa and we compare it to the thickness of the wall, excluding the cartilaginous support. Okay? And you'll notice there's an increase in the thickness of the submucosal glands when you normalize it to the rest of the wall thickness. When we measure that thickness by comparing this ratio, length of the submucosal depth and the thickness of the airway, we get something called the Reed index. The Reed index. Reed index is just a ratio of this length to this length. And the Reed index over here is probably something close to 0.5, whereas the normal Reed index probably something close to 0.33 or something. So you get an increase in the thickness of the submucosal glands as measured by the Reed index, this ratio of lengths. Again, one of the characteristic histologic features of chronic bronchitis.
Dr. Maddox?
Yes.
Tobacco smoke, is it just sort of personal chemistry that would allow like one person to smoke their whole life and live to 85 years old versus somebody who just acquires cancer earlier than that?
I would assume genetics is a big part of that. Maybe some other environmental factors. It's a multifactorial disease. Genetics and environment. Okay. Let's talk about a few more things. Again, the risk factors, exposure to anything that irritates the airway. There's so many things, smoking, sulfur dioxide, et cetera. It's a big one. Presentation, you have a cough, productive of mucus. The mucus will be different color, different consistency, depending upon whether or not there's a pre-existing infection or not. If the mucus being coughed up is relatively clear, that usually will tell you that there's no significant infection. But people with chronic bronchitis have blockages in their airways that predisposes them to infection. So maybe they'll start coughing up some green mucus or some yellow mucus. That's more consistent with an infection. A workup in inflammation in the airways, all kinds of inflammatory cells, but again, there's a conspicuous absence of eosinophils. Okay? Eosinophils not observed in chronic bronchitis. Goblet cell hyperplasia, again, squamous metaplasia. There might even be some dysplasia developing in the airways, which would predispose these individuals to bronchogenic cancers of the lung, lung cancers. Chronic bronchitis thickens the airway walls. It plugs them up with a lot of mucus, so it's very difficult to move air in and out when you have chronic bronchitis. And as a result, chronic bronchitis is classified as a chronic obstructive pulmonary disease. In addition, some of the inflammation can cause stricturing of the airways, again, making it difficult to move air in and out. That stricture is not being reversible, so once again, we classify it as a chronic obstructive pulmonary disease. Okay. Any questions on chronic bronchitis? Okay, another disease classified as a chronic obstructive pulmonary disease is bronchiectasis. Bronchiectasis. Bronchi referring to the airway, ectatic, we talked about that word before, means dilated. This is a disease where you have permanently dilated airways. Okay, except the dilation is related to architectural changes. Not caused by smooth muscle relaxing or constricting. It's caused by structural changes in the airways that permanently widen. And so we call this condition bronchiectasis. And the airways affected are described as being bronchiectatic. Okay. This is a disease principally caused by necrotizing infections. Usually there's some sort of antecedent pulmonary disease that predisposes them to these infections. Maybe they have chronic bronchitis or emphysema. They develop these infections, including staph and TB, Klebsiella. And these bacteria not only infect the airways and the lungs, but they cause destruction of the smooth muscle that controls the caliber of the airway. The smooth muscle ring causes the airways to constrict and dilate. They destroy that smooth muscle. And once that smooth muscle ring is destroyed, there's nothing that controls the caliber of the airway. And over time, the airway just continues to expand without being constricted. And it remodels to adopt really grotesque diameters. That's called bronchiectasis. Let's take a look. Here's what happens. Here's a normal airway. Again, the lumen, the wall. Remember, the wall is surrounded by smooth muscle that controls the caliber of the airway. These necrotizing infections, they destroy the smooth muscle here. That smooth muscle is destroyed by the necrotizing infection. Now there's nothing to control the caliber of the airway, and this is what happens to the airway ultimately. It just wildly dilates. Because of inflammation, again, the airway wall thickens. And because of the infection, there's lots of mucus in here. It's usually some sort of purulent green mucus. People with active infections have their smooth muscle destroyed, their airways are being remodeled and damaged, and they're coughing up a lot of foul-smelling mucus, or fetid mucus. The word is fetid. That's the word we use to describe foul-smelling mucus, fetid mucus. And there's usually blood in the mucus. There's pus in the mucus. That's bronchiectasis. Okay, let's take a look at the airways that are damaged. Okay, so this is a normal airway. We've already seen the architecture of this. Lumen Okay, there's the epithelium right there, it's lamina propria, there's the muscularis mucosa. So this muscle layer here, this muscularis mucosa, that's what's damaged by these infections. A necrotizing infection will completely damage the smooth muscle. Now, that's the only thing that keeps the diameter restricted on this airway. Keeps it in check. Once you wipe out that airway smooth muscle, the airways can just dilate all they want. They just constantly remodel with nothing keeping their airway diameter in check. And so this is what happens. Here's a section through the lungs. And you got the apex of the lung over here. There's the bases of the lungs over there. We're looking at a cut section. Bases look okay. But look at the apices. You see this massively dilated airway with a thick wall. That's a bronchiectatic airway. Okay? That's bronchiectasis. Now, a few problems with that, of course. You get this massively dilated airway. You lose lung pressure when that airway dilates like that. So you're losing gas diffusion capacity. Plus the airways are plugged up with mucus. Plus the airways are flimsy. Even though they have a thick wall, they don't have any structure to them. So they're floppy and they'll collapse during exhalation. They may stricture because of other inflammation and damage. And so, naturally, this presents with an obstructive lung profile. It happens slowly over time. So bronchiectasis is generally classified as a COPD, chronic obstructive pulmonary disease. Let's take a look at these airways, the radiographic appearance of the airways. You can see just how badly dilated the airways are on a radiograph. So here we have two radiographs showing you the large airways with thickened walls. Here's an example of a radiograph catching one of these airways in kind of a longitudinal profile. The airways presenting as two radiodense lines that are parallel to each other. What you're looking at is the radiographic shadow of the walls, casting that shadow on the film. And it looks like you got two parallel radiodensities there. They kind of look like tram tracks, and so it's called tram track. All right. So here's an example of an airway that's kind of cut in cross section. You can see it as kind of a circle here of radiodensity. You notice there's some kind of vague radiodensities around it. That's just due to inflammation. That's called cuffing. It's called cuffing. That's just a dilated bronchiectatic airway. That's a dilated bronchiectatic airway. Okay, that's what it would look like on a radiograph. Okay, there's some other findings in bronchiectasis. It's not specific to bronchiectasis, but you actually see it in almost every severe form of pulmonary disease. It's called finger clubbing. Okay? It literally is a condition where the fingertips take on a different morphology, like a club. Again, it's not something specific to bronchiectasis, but it's something you see in many pulmonary diseases. And of course, the name is very descriptive. It looks like the fingers are kind of dysmorphic. They look like they have a clubbing morphology. Some clubbing is more subtle than others. If you want to really assess the morphology of the fingers, you ask the patient to take the index fingers, put them together like this. If there's a big hole right at the base of the cuticle, okay, that probably is a morphology that's consistent with clubbing. This one's a really severe form of clubbing. And that's not a degree of clubbing you see very often. It's very severe. Okay, any questions on this? Okay, so the pathogenesis, bronchiectasis, again, these are usually infections. Presentation, again, when they have an active infection, they'll be coughing up a lot of foul-smelling sputum, sometimes a lot of blood in it. And you got radiographic evidence of bronchial dilation, cuffing, and tram track. Okay. Now, bronchiectasis is something that develops in a lot of people with some other pulmonary disease. The pulmonary disease predisposes them to these types of infections, and then they develop the bronchiectasis on top of whatever else they have. A very common condition in which we see this bronchiectasis, a lot of dramatic changes in finger morphology like this related to pulmonary problems, is cystic fibrosis. Cystic fibrosis, genetically based disease. It is a disease in which there is a problem with chloride metabolism that ultimately affects fluid shifts. And people with cystic fibrosis have a tough time moving mucus in their lungs because the mucus becomes dehydrated and inspissated, and it kind of gets stuck throughout the lungs. They can't move it very easily. It gets infected, and the lungs get infected, and they develop one pulmonary infection after another pulmonary infection, and ultimately they'll develop things like chronic bronchitis and bronchiectasis, and they'll have dramatic changes to the structure of their lungs, eventually, quite possibly necessitating lung transplants. Okay. So let's take a brief moment and have a look at cystic fibrosis. Okay, cystic fibrosis is a genetically based disease. It's classified as an autosomal recessive disease. Okay, now recall that for every protein you have in your body, generally, you have two genes that encode for it. One you get from the maternal parent, the other you get from the paternal parent. You have these two genes. Now, because cystic fibrosis is classified as an autosomal recessive disease, that tells you that in order to develop the disease, you must have a defect in the gene you got from the paternal parent and a gene you got from the maternal parent. Both of those genes have to be defective in order for you to develop the disease. That disease is referred to as an autosomal recessive disorder, and cystic fibrosis is an autosomal recessive genetic disease. The gene in question is called the CFTR gene. We've talked about this before, I believe. It's called the cystic fibrosis transmembrane regulator. It encodes for an anion channel that principally conducts chloride. And so we call it a chloride channel, even though it conducts other anions. But the importance of the channel is related to chloride transport. Chloride, the ion chloride, its transports are usually related to fluid balance. Where chloride goes, water will follow. And so we mess up the metabolism of chloride and chloride transport. Ultimately, fluid shifts that are supposed to happen don't happen. And that's the basis of this disease. There is a defect in chloride transport. Okay. All right. Typical way that someone will develop cystic fibrosis is when they have two parents that are basically unaffected, both of which are carriers. They don't have the disease, but each of them carries one mutant allele that is ultimately could cause the disease. Okay, Dad has a profile in which he has these two genes. One is normal, one is not. Mom has a genetic profile where one of the genes is mutated, the other is not. And we call that the carrier state. The person with this condition would be manifesting symptoms because they have one good gene. Only one of the genes is mutated. They have one good gene, they can rely on that, and they won't develop disease as a result. However, when they have offspring, chances are that 25% of the time, the mutant gene from dad and the mutant gene from mom are going to combine to have an affected child. And so 25% of the time, when they have offspring, on average, 25% of that offspring is going to be affected. There's a 1 in 4 chance each child could develop cystic fibrosis because they can inherit one mutant allele from mom, the other mutant allele from dad. Let's take a look at this. Look at the karyotype associated with various conditions. Carrier types affected expected offspring. So here's a normal karyotype, okay? We're just displaying all of the chromosomes in a little display, progressing from the largest chromosome to the smallest chromosome. And you recall we have a total of 23 chromosomal pairs, making 46 chromosomes in total. The first 22 pairs are called autosomes, and the last chromosomal pair is called the sex chromosome. Okay? This person happens to be 46XX. We have 46 chromosomes, including these two X chromosomes. That would make this person a genotypic female. We expect, of course, phenotypically the person will be female. Okay. Now, the problem with cystic fibrosis is on chromosome 7. There's a gene there on chromosome 7 called the CFTR gene. Okay. This person has a normal CFTR gene on this chromosome and a normal CFTR gene on that chromosome. One chromosome came from mom, the other one came from dad. So maybe it's the paternal chromosome, that might be the maternal chromosome. But the genes on both of them are normal, so this person's fine, not even a carrier. Here's a carrier state. The person wouldn't be affected, but nonetheless would be a carrier for the disease. Again, this is a female, we would expect. And if we look at the chromosome 7 pair, we can see that one of the two chromosomes has a defective CFTR gene. Okay. This person would not be affected by the disease, but nonetheless would be a carrier. Here's an affected individual. Again, 46XX, expected to be female. This person has inherited a defective gene on this chromosome and a defective gene on that chromosome, one from mom, one from dad. That person has two genes that are affected, mutated. This person we would expect expressing the disease. It would be a disease phenotype. That's the genetic profile that's going to be affected. Okay. All right, so let's have a look at the problem. So I said the defects on chromosome 7. Okay, there it is on chromosome 7. You can see it's a depiction of chromosome 7 with typical G banding. Long arm of chromosome 7, you find the CFTR gene. There it is right there. The CFTR gene encodes for this, the cystic fibrosis transmembrane regulator. It is just a pore that spans a phospholipid bilayer. Its primary function is to conduct chloride. And you can see there's the phospholipid bilayer, and embedded in it, you can see this protein pore. That's the CFTR. The CFTR has a number of regulatory domains and nuclear binding folds, but the principal issue we want to, the principal function is related to that pore right there, conducts chloride. All right, let's see how it normally would operate in the lung to our benefit. So we have a depiction of the respiratory epithelium here. There's the lumen of the airway. Now we know that we have goblet cells in the airway. They're going to produce mucus. They're going to layer the pseudostratified ciliated epithelium with that mucus. The purpose is, of course, to entrap garbage that we happen to inhale, the cilia, move it up to our oropharynx, we swallow. In order to move that mucus, though, it has to be very fluidic. It has to be easy to move. It has to be like semi-fluid in order to get the cilia to move that up. Well, it's kept fluidic by constantly diluting it with water. Okay? And the water that enters the mucus is propagated by the cystic fibrosis transmembrane regulator. Here's an epithelial cell with the CFTR, and you can see the CFTR conducts chloride into the mucus. You got the chloride out here. Now, when the chloride is in the mucus, sodium is going to follow it, so you get a lot of sodium chloride out here, a lot of salt. Salt is osmotically active. It's going to pull with it a lot of fluid, so you get this mixture of mucus and fluid. The fluid makes the mucus very fluidic, easy to move. Okay, move that mucus right up there. Here's an example of an airway in which the CFTR is not working. CFTR does not conduct chloride. There's no chloride in the mucus. No sodium is going to get in there. Water is not going to follow. So what happens? This mucus gets dehydrated, and it forms these little concretions. It becomes inspissated. That just means it dehydrates. Inspissated. hard to move that mucus. Mucus stays right where it is. It gets infected, and the lung just gets one infection after the other. And you start off with some bronchiectasis, some chronic bronchitis, some pneumonias. Okay. People with cystic fibrosis constantly getting infections. They're constantly on antibiotics, and eventually they become allergic to every single antibiotic you can think of because it becomes very difficult to manage infections. Okay, any questions on the genetics? All right, let's take a look at an example of one mutation that's responsible for a CFTR that does not work. CFTR becomes disabled as a result of mutation. It's not going to conduct chloride. Okay, one of the common severe mutations that affects the CFTR gene is called the delta F508 mutation. Delta stands for deletion. F is the amino acid phenylalanine. 508 tells you its position in the protein. Normally, there is a phenylalanine in the 508th amino acid position counting from the N-terminus of the protein. Count from the N-terminus of the protein, position 508, you should find phenylalanine there. The most common severe mutation in cystic fibrosis is one in which that phenylalanine is deleted, and the protein is produced without that phenylalanine in the right position. It results in a dysfunctional chloride channel. It doesn't conduct chloride. So this mutation is called the delta F508 mutation. Here's what it looks like. Okay, here we have depictions of DNA. They're grouped into trinucleotides that correspond to ultimately codons and amino acids. They're going to be incorporated in the protein. So here's what normal DNA looks like. You got a sequence ATC that encodes for an isoleucine, another ATC that encodes for an isoleucine, a TTT that encodes for the phenylalanine of interest, and then a GGT that encodes for glycine. In this mutation, there's a deletion of 3 nucleotides. These 3 nucleotides get deleted. As a result of a deletion of those 3 nucleotides, the phenylalanine is lost from the amino acid primary structure. So let's take a look at what would happen. Here's the mutated DNA. We still have an ATC like we did before, that encodes for an isoleucine. The next trinucleotide sequence is ATT instead of ATC. Well, that also happens to encode for an isoleucine, no problem. But the next trinucleotide that is red is a GGT that encodes for a glycine. What happened to the phenylalanine? It never gets incorporated in the growing amino acid, the growing protein. And so there's a deletion of the phenylalanine because there's a deletion of a trinucleotide sequence in the DNA. That results in a loss of an entire amino acid, the phenylalanine, that should have been in the 508th position counting from the N-terminus. Well, that's the most common mutation, a severe form that causes cystic fibrosis, the delta F508 mutation. Okay, so what other problems do people with cystic fibrosis have? So mainly when we think of cystic fibrosis, we think of it as a pulmonary disease. And that's true. Probably the most significant manifestations involve the lungs and ultimately the heart. But there are problems with a lot of different systems simply because water balance can't be achieved without that chloride ion working properly. And so people with cystic fibrosis have other problems. Yes, their airway is constantly being infected because the mucus is not very thin and fluidic, it's very thick and it's inspissated. Patients will have problems with their sinuses. They have chronic forms of sinusitis. They have problems with their pancreas. The pancreatic secretions are supposed to be fluidic. Without chloride working, the pancreatic secretions are very thick and viscid, and they form concretions, and they clog up the pancreatic ducts, causing chronic pancreatitis. And the pancreas ultimately becomes very fibrotic and cystic, which is where the name cystic fibrosis comes from. It's actually named after the appearance of the pancreas. The bowel fluids also can sometimes be improperly balanced. In fact, sometimes children are born with meconium ileus. Meconium ileus. Normally when a child's born, they'll pass meconium from their anus. It's kind of a greenish material. It's normal. They should pass this material. It's a bunch of desquamated cells and mucus. They should easily pass that sometime after birth. Okay? It's meconium. People with cystic fibrosis can't pass that material because it's too thick and it obstructs the bowel. That's called meconium ileus. Now, it doesn't happen very often in patients with cystic fibrosis. Meconium ileus only affects about 10% of people with cystic fibrosis. But when a child presents with meconium ileus, first thing on your differential is cystic fibrosis. Some other interesting things happen. The sodium chloride in people's sweat is not properly balanced. Not only we spill out a lot of sodium chloride along with the sweat, but a lot of that sodium chloride is resorbed if we have the proper channels working to do that. People with cystic fibrosis sweat, they produce a lot of sodium chloride on their skin, but it's not resorbed. It's left on the skin. And as a result, they have very salty skin. Sometimes the mother will actually tell the clinician something very odd that will make the clinician think of cystic fibrosis. Sometimes when the mother is kissing the mother will say that the child tastes very salty because the salt is left on the skin. And as a result, cystic fibrosis has an alternative name. It's called salty baby syndrome. And very often, especially in the past, mothers would actually make the diagnosis of cystic fibrosis when they say, gee, that child seems awfully salty. Okay, any questions about that? Okay, lots of other problems, I'll just mention them, then we'll finish up. Liver complications, again, not a very common complication, but the liver can get obstructed, all the biliary channels can get kind of obstructed, causing hepatic cirrhosis. Liver will scar down as a result of that. Men generally are infertile. They develop immotile sperm, that's called azoospermia. Okay, they may even have a complete absence of the vas deferens. Okay. Women also have a decrease in fertility. Maybe they're only 50% as fertile as a normal woman. Again, that is because of the ciliary dysmotility of the tubes. Okay, also some other problems. Any questions on cystic fibrosis? Okay, we'll wrap for today.